First of all, I want to thank Bashar and the organizing team for this really very valuable program. I'm more than happy to participate and help in any capacity. I choose the case that I recently encountered here, and I want to share with you my experience and just discuss a few subjects through the case. So this is a 58-year-old male who presented with progressive dyspnea for last 6 months. Basically, he was admitted to an outside hospital with acute worsening of this dyspnea over a short period of time. 4 days, he became extremely dyspneic and went to this kind of mid-sized hospital and said, I cannot breathe. He was found to be in a lot of trouble, and he was admitted there to their ICU. Just shortness of breath. He has no cough or sputum production or any of the symptoms. He had no fever or chills. He had no chest pain or palpitation. And basically, his past medical history is significant for 2 episodes of DVT in the past 3 years. He has a history of paroxysmal AFib that was fairly controlled, and history of hypertension. He is a non-smoker. He has been maintained on blood pressure medicine and a diuretic. And his typical blood pressure runs around 130, 140, systolic. At the outside hospital, these are his numbers, and this is when we got a call about his transfer to our hospital. So he was a bit on the lower range of normal blood pressure, 95/60. He was tachycardic, and they reported irregular heartbeat, afebrile. He was profoundly hypoxemic with saturation around 88% on 5-liter nasal cannula. His examination, per report, he had significant elevation of his jugular venous distension, JVD. He has bilateral crackles and has +3 thinning edema in his lower extremities. So on admission, they did a chest X-ray and reportedly showed cardiomegaly and some pleural effusions. His EKG showed AFib with controlled rate. The echocardiogram from outside showed biventricular dysfunction. Both right and ventricle and left ventricle were impaired. And on the right side, the right ventricle was more dilated than the left. And of course, they did some sort of imaging, and I'm gonna try to show you his initial chest X-ray. So just to kind of remind you, this is a portable X-ray. So patient was in supine position. So what you're seeing is exactly right. You described very well. So you have evidence of really massive cardiomegaly, and there is this opacity here. Because you don't see really the diaphragm on either side. And it looks like there is some grading of that opacity, which suggests probably a pleural effusion or something like that. And you can, make all kind of assumption. Could be a consolidation, atelectasis collapse in the right middle lobe because I don't see the right heart border. So the X-ray, and the other thing that is really important, do you guys see any pulmonary edema? And that's what I was trying to say. The lung looks clean. It doesn't look like there is pulmonary edema. And you have this relatively young man with profound hypoxemia and this kind of X-ray. So just to save time, I'm going to show you when you get this. Nowadays, almost the emergency room physician tend to jump straight to a CT scan, and that's his CT scan. So I'm going to show you just some images for those who are not really familiar with reading CT scan. This is your pulmonary artery. This is your SVC. You see the contrast on those 2 vessels. This is your ascending aorta, and this is your trachea. This patient appeared to have tracheomalacia. You see how the airway is kind of compressed. This is your descending aorta. And within the trunk of the pulmonary artery, you see this thing here. There is a filling defect in that pulmonary artery. And going into a lower section of that CT scan, you can see there is a large filling defect in that pulmonary artery right there. there's some contrast moving through, even though there's almost a cutoff completely in one end. And you don't see anything distally. And if you look at the left lower lobe or left main pulmonary artery, there is a big eccentric filling defect in that pulmonary artery. Going further down, you see there is a filling defect in the left lower lobe pulmonary artery. You don't see any contrast, maybe barely some contrast going into the right lower lobe. And and you can see this medium-sized pleural effusion with some partial collapse of that right lower lobe. And I have to show you the rest of the images. You can see this is your right ventricle, and this is your left ventricle. And it's a beautifully contrasted study. If they give you a CT scan for PE, this is how it should look. You shouldn't see any contrast with the left side. This is a perfectly contrasted study. And the right ventricle is definitely dilated because almost equal size to the left ventricle. And that right atrium is massively dilated. Coming further down, I want you to start paying attention when you see these CT scans. You see contrast. The contrast was given in the upper extremity, and you see contrast going deep into the liver. This is the hepatic vein. And you see retrograde flow of that contrast into the hepatic vein, indicating that the pressure on the right side of the heart is very high. So this is something we look into when we evaluate these patients. I'm going to show you the lung, one slide of the lung images, and you can see the lungs are clean. There's no pulmonary edema. There's no infiltrate. So that's his initial CT scan. So as I showed you, there are on that CT scan, there's bilateral extensive filling defects. And now I didn't go into the details how we can differentiate between acute and chronic clots. I have a slide on that in a minute. So what that CT scan, which we repeated in our center, showed exactly those findings. There is, it looks like an acute on chronic process here with clots everywhere, especially on the right side of the pulmonary circulation. The right lung has very minimal blood flow. And as I showed you, the right ventricle is dilated, right atrium is dilated. There is a right pleural effusion. This is his initial EKG, and actually I kept the reading here, so it's very obvious for the group. You can see there is AFib with the rapid ventricular response rate is around 120. And you can see the pattern that's consistent with right bundle branch block, which we can talk about a little bit more in this setting. So as I showed you, he has AFib with RVR, echocardiogram, shows preserved left ventricular function. And this is our echocardiogram here at UF because they described biventricular failure. So we did our own echo. And the left ventricle looked completely normal. And the left atrium is normal. The mitral valve, aortic valve, all looked good. His right ventricle is severely dilated and dysfunctional. The right atrium is very dilated. And we estimated his right ventricular systolic pressure to be around 90. This is his initial labs on arrival to our ICU. His NT-proBNP, which is a marker of atrial stretching, was severely elevated. His troponin was normal. His creatinine was mildly elevated. His liver enzymes were 2 to 3 times normal. CBC showed mild anemia. His platelet count and WBCs were normal. So I'm going to stop here and let's start the discussion with what's the diagnosis here and what would you do next? So what are we dealing with? I think I gave a lot of the diagnosis, but I just want to see how we think about these patients. So the picture here is you have a young man with chronic dyspnea for 6 months who has an acute decompensation, comes in with profound hypoxemia, borderline blood pressure, and was found to have multiple large clots in his pulmonary artery. The right ventricle is dilated and has evidence of pulmonary hypertension on echocardiogram. So our diagnosis is there is pulmonary embolism for sure, based on the story, the imaging. We think this gentleman had for sure an acute component of this acute PE, but probably there was an underlying process that has been going on for some time before, and now we're seeing the decompensation phase. So my diagnosis at this point, this patient has acute on chronic PE. There is evidence of significant right ventricular dysfunction, and he's profoundly hypoxic. So what would we do next? So how do you manage this patient? An approach to acute PE, that's what I'm kind of getting to. How do we manage someone who comes to the ICU? So we're going to treat his PE. And if I want to ask the group, if this guy is going to die, acute PE patient, they typically die from right ventricular failure. This guy is in trouble because there are a lot of things to suggest that his right ventricle is in trouble. And when we think about treating PE, we try to tailor our therapy based on the risk of dying. So when we see acute PE, we think of those patients in different categories. I don't know if you guys are familiar with the so-called high-risk PE, intermediate risk PE, and what we call low-risk PE. And that risk stratification is based on how the clot burden in the pulmonary circulation is affecting the right ventricle. They rarely die from hypoxemia. They typically die from right ventricular failure. So when we think about treatment, what Dr. Ali kind of discussed, I think these are exactly normal treatment we give almost to all patients with acute PE, but some of the patients may need more aggressive therapy. So that's kind of where I'm getting to here. So I'm showing you the approach we felt, as you said, this is an acute on chronic PE, and we, based on the data we have, as I showed you, without repeating myself again, we felt that the patient has intermediate to high-risk PE. High-risk PE, what we used to call massive PE. The word massive PE, we don't like to use it anymore in the pulmonary vascular kind of field because it doesn't reflect what that means. Massive PE means just a big clot and the patient is doing well. That is not really, doesn't tell you that the patient is in trouble. High-risk PE means a patient is at a very high risk of dying. That's what we think of massive PE. So this patient clearly, probably the most important criteria we use to define high-risk PE is hypertension. So blood pressure less than 90, that's by definition. But that's not written in stone. If your patient lives with a blood pressure of 170 and comes to you with a blood pressure of 110, that is shock, okay? This particular patient had a borderline elevated lactate on admission. I didn't give you that piece of information. So it's not, that definition of high risk is sometimes can be a little vague. So that's why we called it intermediate to high risk PE. And given the severity of the hypoxemia and kind of borderline instability, we decided to give him a low dose TPA. And I'm not going to get into this management of acute PE in more detail, but I want you to understand the standard dose is you're going to give 100 milligram of TPA. That's your standard therapy for massive PE. We give this guy 50 milligrams TPA for multiple reasons, and that part of it is there was some worried about he had recent fall, and we don't want to increase the risk of massive bleeding. Typically, when we give a TPA to a patient with acute PE, they tend to have a very rapid response. Means their blood pressure improves, their oxygenation improves, and they tend to really turn around very quickly. We're talking about within a few hours. So this guy came to us, we admitted him to the ICU, we gave him that TPA, and we monitored him. Nothing changed. He continued to be profoundly hypoxemic. So pulmonary artery or pulmonary hypertension is the pressure elevation in the pulmonary artery. And there are many different ways that this disease process happens. So you have what we call pulmonary arterial hypertension. There is a disease in the small blood vessel that obstruct those blood vessels. And we treat this sometimes with pulmonary vasodilator, the one you were mentioning. Some patient may respond to calcium channel blocker, but this is extremely rare. A lot of patients would respond to therapy. The most effective is the prostacyclin, the one you mentioned, IV prostacyclin. But not all pulmonary hypertension is caused by the same process. In this patient, what caused the high pressure is the obstruction of the pulmonary vascular bed. So I want just to share with you some very simple physiology. The pulmonary vascular bed, the amount of blood flowing through the pulmonary tree, it is built in such a way it has tremendous capacity to deal with flow variation. If you obstruct more than 70% of your pulmonary vascular bed, you're going to develop pulmonary hypertension. If you have a small clot that obstructs a small portion, let's say 30% of the blood flow, your pressure would remain normal. So in this patient, the clot burden, the obstruction, is the primary driver for the high blood pressure, MV, the pulmonary hypertension. So the way we think about treating it is I want to relieve that obstruction. So giving the TPA is a good strategy because I know the obstruction is coming from the clot. But what you said is very appropriate. I want you to think about approach to pulmonary hypertension. There's many different ways we treat this condition. So in this particular case, we felt the acute clot may be a big contributor to his decompensation. But as you can see, we gave the TPA, no major change. And the second piece that I am trying to point out, and I think most of you have recognized, that the patient has signs of right ventricular failure. And what I mean by that, the patient has very dilated right ventricle. He has borderline low blood pressure. You have raised JVD. He has congestive hepatopathy with the elevated liver enzyme. You have +3, +4 lower extremity edema. And when we think about ventricular failure, we always think of whether it's an acute or chronic. And the reason I'm putting those together, so I want you to think about this when the patient comes to you. Someone is healthy without any cardiopulmonary reserve or limitation, comes in with acute right ventricular failure, that's an acute right ventricular failure. Someone who has this protracted chronic condition that appears to be associated with volume overload, probably they have a component of chronic process, and now they have an acute on chronic process. So I want you to recognize this concept of acute on chronic. Acute PE, the patients with acute PE don't have massive peripheral edema. It will be edema from the DVT, not from heart failure. This gentleman has massive anasarca, diffuse edema. So that's another concept. So just going back to the management of right ventricular failure, regardless of what's causing the problem, because remember, the main or the major cause of death in patients with pulmonary hypertension is right ventricular failure. So the way we treat the right ventricular failure is fundamental, and we all should be familiar in the ICU with recognizing right ventricular failure and how we treat it. Right ventricular failure is sometimes more dangerous than left ventricular failure. And those patients get in trouble very quickly. So how do we treat acute on chronic, or for that matter, acute ventricular failure? I'm sorry, I forgot the name of the person who spoke last, but those are basic fundamental concepts that I would like to keep that in mind. So most patients that comes to you with acute or chronic right ventricular failure, they tend to have volume overload. And in most cases, we need to diurese them. What you want to use, it's up to you. I think loop diuretics are the most powerful agents. And I want you to think about it in more very basic concept here. So we need to optimize the right ventricular preload, which is the filling pressure of the right ventricle. That's your volume overload. So we put them on Lasix drip. The challenge with that, sometimes patient can be hypotensive. You need to pay attention to that. You don't just push the Lasix drip without paying attention to the blood pressure. The second concept here, I'm trying to make the ventricle happy without overstretching. So I'm diuresing the patient. Then I'm going to try to improve the contractility of the ventricle. So I give them inotropes, milrinone, dobutamine, any of these agents are reasonable. In this patient, we gave this patient milrinone, which is a very effective inotropic agent, and it has other characteristics of advantages to using it. We put the patient on milrinone drip, and what we did, we said, okay, why don't we give him something? We already give the TPA to reduce the pressure in the pulmonary circulation, and it didn't work. So we have to add pulmonary vasodilating therapy. So immediately in the ICU, we added inhaled nitric oxide. I don't know if it's available in Jordan or other places, but this is a very powerful, rapid-acting pulmonary vasodilator agent that is extremely helpful in ICU setting. That's what we did immediately. And as I showed you, the patient has borderline blood pressure. His systolic pressure was like 95. So what we call shock is 90 or less. And this guy lives with a blood pressure much higher than that. If you put a patient on milrinone and you give them Lasix, guess what's going to happen to them? They're going to be hypertensive. And that hypertension can lead to rapid right ventricular failure, and that can be disastrous. So most patients we treat with right ventricular failure, we give them these medications. We almost always add a systemic vasoconstrictor, something that will constrict the peripheral circulation, not the pulmonary circulation. And there are a few drugs that we often use. Levophed is the most frequently used drug, but you can use vasopressin also. And we tend to optimize oxygen as much as possible, as in this case, we put him on another breather. And even for a period of time, he was on BiPAP for a period of time. So that's kind of where we are. We gave him treatment. He did have a little bit of improvement. And we said, okay, at some point, we're going to have to really define his hemodynamic and find out what else is going on and define his pulmonary hypertension specifically. So pulmonary hypertension is a diagnosis that we sometimes suspect clinically. We use an echocardiogram to start the process of the evaluation. And echocardiogram is not a definitive diagnosis of pulmonary hypertension. Pulmonary hypertension is only confirmed by doing a right heart cath. And we took this guy after a week or so of optimizing him. We took him to the cath lab and we did a cath. And this is so when we do a cath, normally we go through the jugular. This is what I do, go through the jugular vein, go into the superior vein cava, then the right atrium, where there is a balloon, the tip of that catheter, we float them into the right ventricle, and then to the PA, and we do the wedge pressure. So this is kind of sequential going through that process. So his right atrial pressure, or what we call CVP, was 26. A normal CVP is maximum 10. So 8 is normal. Very high. So there is a very high filling pressure. And the reason for that is what? I think next comes the right ventricle, when we go into the right ventricle. So that gives you a sense that the right ventricle is struggling to push the blood forward. So that's a marker of right ventricular failure. When you see a very high right atrial pressure, that's a marker of right ventricular failure. We went into the pulmonary artery, and this is the mean. The systolic pressure is 85. His diastolic is 30, and the mean PA pressure is 44. Is that normal, abnormal? So a normal PA pressure, the mean PA pressure nowadays, we define it as 17. Anything less than 20, we accept that as close to normal. So anything more than 20, we call it pulmonary hypertension. That's how we define pulmonary hypertension, by hemodynamic criteria. And I want to stop here for a second, because this is an important piece going back, and I'm going to finish the rest of this, but I want to pay attention to these numbers. So this is a gentleman, we said he has acute, probably acute PE on something chronic PE. And this is where I want you to start paying attention when it comes to echocardiogram or right heart cath. A normal individual with normal pulmonary circulation should have a mean PA pressure around 14. And when you do an echocardiogram in normal healthy people, their systolic pressure, or what we call right ventricular systolic pressure estimation by echo, should not exceed 35. If a patient comes to you in acute PE and their RVSP by echocardiogram, which is an estimation of the right ventricular pressure, or if you cath them and they have a mean PA pressure that's high, this is not classic acute PE. So the right ventricle is a very weak structure. It's not very strong like the left ventricle. It can generate very high pressure. The right ventricle is not made to generate high pressure. So if you have a massive PE with a normal right ventricle, your systolic pressure should not exceed 50 or 60. I hope that concept is clear. So that pulmonary artery systolic pressure should not get anywhere near 70 or 80. So this is a marker of chronicity, that the ventricle is able to generate high pressure. So you have an acute PE patient coming to you and you do an echo and your right ventricular estimation, your cardiology colleague tell you, hey, the RVSP is like 90 or 100. And you want to pay attention. This patient does not have acute PE only. He has chronic pulmonary hypertension with an acute PE problem. So just remember that fact. Acute PE, the systolic pressure should not exceed 50. Going back to the case, the wedge is 11. Is that normal, abnormal? What do we think? That's a very good point. I think normal should be around close to 10. You're correct. But we have to put a cutoff criteria. So we normally consider acceptable or normal, and the reason why I say this is less than 15 is acceptable. We call it, there is no high venous pressure. So we call it that there is no problem on the, so blood flows from the right ventricle into the pulmonary artery, pulmonary capillaries, pulmonary venules, pulmonary veins, left atrium. If there's blockage or failure on the left side of the heart, your pulmonary vein pressure goes up, the pulmonary capillary pressure goes up, and that gives you a high wedge pressure. So a wedge pressure less than 15 is considered a normal wedge. What that means, the pulmonary hypertension is not due to left heart disease. This is not due to systolic heart failure, diastolic heart failure, mitral stenosis. All these conditions makes your wedge high. That wedge is normal, means the pressure problem is caused by something on the arterial side. And in this case, we know there is a clot. There is a clot in the big pulmonary artery. Going further, we measured the cardiac output, and his cardiac output was 4. And I like always, 4 means nothing unless you know how big is this individual. His cardiac index, which takes the body mass into consideration, because the bigger you are, the more cardiac output you need, is 1.8. Is that normal, abnormal? Less than 2.5 is abnormal. And if it's less than 2, it's really, really bad. It means the cardiac output is impaired. So when you combine the 3 conditions that I mentioned to you, that the cardiac output is low, the right atrial pressure is high, and there is high pressure, it tells you what? That pressure is generated by the right ventricle. The right ventricle is the one that squeezes the blood that gives this pressure high. So when you have the pump, which is the right ventricle, is unable to move the blood forward because the cardiac index, cardiac output is low, it tells you that the right ventricle is unable to move the blood forward. That's a classic definition of right ventricular failure. You have low cardiac output, high pressure, and the chamber that sits behind the right ventricle, which is the right atrium, has a very high pressure. There's a lot of blood waiting to be moved through that pump, and that pump is failing. That's the hemodynamic definition of right ventricular failure. First question is, what is the RVSP, the right ventricular systolic pressure? This is an estimate that we use an echocardiogram to give us a sense of what the right ventricular pressure looks like. So it should correlate with this number, which is the right ventricular or pulmonary artery systolic pressure should be equal to the right ventricular systolic pressure. And this is why I want you to pay attention. The reason this is a classic case, the right ventricular systolic pressure by echo is an estimate. It's not accurate. It's almost always different than, it should be close, but it's not identical. The echo has significant variability. So remember that never make a final diagnosis of pulmonary hypertension without right heart cath. So that RVSP should be and in theory, should be equal to the pulmonary artery systolic pressure. So that's exactly right. So the mean is the main criteria we use. But I want you to remember that the systolic pressure by cath may be different than right ventricular systolic pressure by echo, because that estimate, this is an accurate, this is the definitive number. The mean is a formula that take into account diastolic and systolic, and that's where, as Dr. Bashar mentioned, we have another variable here we use is called pulmonary vascular resistance, which measures amount of resistance across the pulmonary circulation. It's 8.4 Wood units. Is that normal, abnormal? What do we think? Okay, so pulmonary vascular resistance in normal people, all of you guys, if we cath you, you're gonna have pulmonary vascular resistance 1. And most healthy people, up to 2 is acceptable. Anything more than 2 is abnormal. Okay. For the pulmonary hypertension, we use a cutoff of 3, most cases, but 2 is your magic number. That's your pulmonary vascular resistance. So this patient has a very high resistance in his pulmonary circulation. Why? It's very obvious. It's in our face. There's a big blockage of his pulmonary circulation with large clot or something. Then this is what we call mixed venous saturation, or SVO2, and it's 70. So it should be 70 or 75. Anything less than 65 we consider very abnormal. And this patient has a very low oxygen saturation. It tells you that he is unable to deliver oxygen to the tissue. So taking all that into definition, we, as a pulmonary hypertension doctor, this is my definition of what this cath shows. This patient has pulmonary arterial hypertension. Why I say pulmonary arterial hypertension? It's not pulmonary venous hypertension. The wedge is normal. The PA, mean PA pressure more than 20. And what I say, pulmonary arterial hypertension with high risk features. What are the high risk features? There is evidence of right ventricular failure. The right atrium is very high. The cardiac index is very low. The PVR is very high. And the saturation is low. And I showed you what right ventricular failure means. Okay? So this patient clearly has a very high mortality if we don't treat him. So we decided, okay, let's repeat the CT scan and see if the clot material changed. And guess what? That's after the TPA. This is almost 10 days to 2 weeks after the initial TPA. So you guys can see there is still a big clot there, the same, no changes at all. So no change in the clot burden. And so what we think this patient is really having maybe very mild acute different condition. There is a condition called chronic PE, and the more often used term that we use for this condition is called chronic thromboembolic pulmonary hypertension, and I'll explain that in more detail in a second. So most patients with acute PE, the clot will go away, but for a small percentage of patients, that clot doesn't go away and turn into scar tissue. So after a while, it's not really a clot anymore. You can give all the TPA in the world, it doesn't make it go away. That is a scar tissue. It's a fibrous tissue that organize and obstruct the blood vessel. And we diagnose this with CT scan, but more often, just I want to make sure everyone gets familiar with this concept. We use the VQ scan to show that there is obstruction of blood flow. I know this is maybe a little bit more tailored for pulmonary indicators, but I want to show you one image. So we do an IV injection of a radioactive material that gets filtered in the lung, and we give them something radioactive to inhale. So we look at ventilation and we look at the perfusion. And I want you to pay attention to these two images. This is what we call anterior view of the lung, and this is ventilation, and this is perfusion. And this is your right lung, left lung, the heart sits here, right, left lung, right lung. And you can clearly see that the ventilation, the top one is the ventilation, this is perfusion. The right lung has beautiful ventilation, but almost no perfusion. And this is what the CT scan showed you. I'm just proving it to you with the VQ scan. This is what we call high probability PE. So, And without going into all the details, that's what they describe a large mismatch defect on VQ scan. This is high probability PE. So I hope when you hear that term, that high probability PE doesn't always means acute PE. You can see this in acute PE, you can see this in chronic PE. Why I say this? Because a patient with chronic PE, you can give them all the therapeutic treatment that you have. It's not going to change the course. The patient will continue to be in trouble. You're not going to fix this with TPA. So this is just a teaching point. I want you to know VQ scan does not differentiate between acute or chronic, but it probably more favor a chronic process. Okay, so this is what we call high probability VQ scan for a PE. And in the setting that we are dealing with, I think confirms what we are talking about, which is the patient has chronic thromboembolic pulmonary hypertension. So this is kind of the course, and I'm going to try to go through this quickly to show you what we did with this case. So we treated him for right ventricular failure. We gave him milrinone, high-dose diuretic therapy, Lasix drip. We pushed it really hard. We had him on levofed. Actually, we added even vaso to maintain his blood pressure. We gave him nitric oxide, and there was no major change in his condition. We added additional pulmonary vasodilator therapy. We put him on IV treprostinil, which is one of the most powerful. It's like Flolan agent. We added other therapies. There are two medications. Some of you are not familiar with. These are very effective therapy we use for patients with pulmonary hypertension to open the blood vessel to see if we can get more blood flow through that pulmonary circulation. No change. He remains severely hypoxemic and volume overload. We keep pushing hard to the point where we start having renal dysfunction. And this is a concept I want to introduce to you guys to understand that diuresis will help, but there is a threshold after which if the heart is unable to move the blood forward, you're going to cause pre-renal azotemia, and that can turn into acute renal failure. So this patient, despite optimal therapy, we did everything. We unloaded the ventricle. We gave anitrope. We gave him pressors. We gave oxygen. We gave all therapies. And we pushed diuresis to the limit. He developed acute renal failure. And we had to start him on CVVH to try to optimize, take some fluid off. And now that kind of we're getting to the point where now it's really requiring a very high specialized place to manage this patient. So we are dealing with refractory right ventricular failure. What I mean by refractory, you tried maximal therapy and the patient is not getting better. And this patient will get in trouble. And most of these patients, I want you to get familiar with this concept. Most of these patients will end up with a PEA arrest in the ICU. So in your ICU, PEA, I want you to think about acute RV failure. Those patients go into a PA and they turn into ugly rhythm after that. So that's your refractory RV failure. And so in general, depending on what is causing RV failure, we treat them with what I outlined to you. But is there anything else we can do? If you were in a magic place with everything, like surgical thrombectomy? So the question is, if the patient continues to be hypertensive and able to move the blood, sometimes we do ECMO. Put them on, an ECMO support to help right ventricle. And I'm not going to get into the ECMO discussion. I have a presentation of that to you guys. I gave it last year. I'd be happy to talk about it in the future. But ECMO support can buy you time until you figure out what needs to be done. But that's back to what Ali was talking about, something called pulmonary endarterectomy. And I want to stop here for a second. So as I told you before, there is acute PE, and sometimes we do thrombectomy. We go in and remove the clot. But trying to do a thrombectomy, and we can do this thrombectomy by different ways. We can do medical thrombectomy. We're giving TPA, it will milk the clot. We can do catheter guided. We consult the interventional team, radiology, and they go on, or sometimes cardiology, they go in with specialized tools through a catheter. We put a PA catheter or a special catheter into pulmonary artery, and we can either suction or manually remove that clot by different means. So there's catheter thrombectomy, but there is sometimes, and we've done this where we took the patient, put the patient on ECMO, patient went into PEA, we took him to the OR and we did surgical surgical thrombectomy. It was a fresh clot. But there is something, this is different. This is endarterectomy. This is like the clot becomes part of the blood vessel wall. It's a fibrous tissue. So you go in and remove the material. It's not really a clot anymore. And this is what happened with this patient. But that time you can see that he had multi-organ failure. He has cardiogenic shock because he was on multiple support for his right ventricle. He has respiratory failure with the profound hypoxemia. He has acute renal failure. So this gentleman has a mortality over 90% and we exhausted all the therapies with him. And so we talked to the family and we told them, listen, we tried everything and this guy's going to die if we don't give him the only hope for his treatment, which is pulmonary endarterectomy. And they agreed and we went to the OR. And this is, we're not going to get into extreme detail. Actually, this is a fascinating case. I was in the case, most of the case. And so we do a bilateral pulmonary endarterectomy. We put the patient into cardiac arrest with deep hypothermia. We're talking about temperature of 20, 15 for a period of time. We open the blood vessel, the pulmonary artery, and we create a new lumen. We shave the vessel from inside and create a new lumen and remove that material. And I'm going to show you what we got out from this guy. This is what we found in the right side of those big organized fibrous tissue. You see that yellow stuff? This is fibrous tissue from around this organized material. All of this came from the right main and segmental branches, lobar and segmental branches on the right side. And that's what came from the left side. You see how it's branching out? So immediately, I took him back to the ICU. He had a PA catheter in place and his PA pressure improved dramatically. Actually, by the time we got to the ICU from the OR, his mean PA pressure was 25. His cardiac output was 7. And made a very remarkable recovery. We extubated him the very next morning. We weaned the pressure. His post-operative course was a bit challenging because, you do this major surgery under cardiopulmonary bypass, there are complications comes with it. Thrombocytopenia, bleeding, all that stuff. But luckily, we managed all of them. He had a bit of fusion, all these complications, they were transient and they recovered nicely. And he made a very rapid improvement, and we weaned the oxygen off. His renal failure recovered very quickly within a week or so. We stopped dialysis and just transferred him to the floor, weaned the oxygen to room air. We continued to optimize his volume status, and we started him on blood thinner, which is the main therapy. And you didn't see me talking about pulmonary hypertension because he does not need any more pulmonary hypertension medication. The treatment for this condition is warfarin. This is what we send him home on. And I recently saw him like last week in the clinic, and his echocardiogram is remarkably better. His right ventricle is still dilated, but much better. And left ventricle is completely normal. He's walking back with his family. His renal function completely back to normal at the time of discharge. And this is an X-ray when I saw him in the clinic last Friday. So just going through a few things, when we see a CT scan, and again, this is more tailored for pulmonologists, when we see a PE, is it acute or is this a chronic thromboembolic parameters? There are some features that sometimes help us look at this. If the pulmonary hypertension is long-standing, you're going to see right ventricular dilatation and hypertrophy. In acute PE, you can see RV dilatation, but the ventricle wall is not thickened. We see dilation of the bronchial artery more in the chronic You don't see bronchial artery dilatation. So there are other features that sometimes we use to help me figure out whether this is acute or chronic. And we looked at a lot of these things in this case. Just to briefly remind you what this condition, and I'm not going to get into a lot of details. CTEPH is a group of pulmonary hypertension. It's called group 4. And I want you to be familiar because this is a treatable disease. PH is not curable disease. This one is curable. Surgery will fix the disease. And they live a normal life. So if you take all patients with acute PE, 4% of patients will end up with this disease. I want you to remember this. 1 out of 20 patients with acute PE may end up with chronic thromboembolic pulmonary hypertension. So we're going to see a lot of these patients. They exist everywhere. I'm sure there are many patients with CTEPH in Jordan, but we need to kind of start recognizing this. How do I diagnose this patient? I treat someone with acute PE with anticoagulation and they get back to normal. I repeat the VQ scan after 3 months. If the VQ scan still shows high probability PE, then this patient probably has CTEPH and need to be evaluated by pulmonary hypertension doctor. So how they present similar to PH, and I'm not going to get into all these things. Dyspnea, sometimes when they have, in this case, he came to us a little bit late with heart failure, with the lower extremity edema. Some time they present with syncope. And this particular disease is curable. That's why I'm pushing this to make sure everyone gets familiar with this. If untreated, the survival is 10% after 5 years if your mean peer pressure is more than 50. So it's a terrible disease. People will die. And there is a cure for it. It's called surgical pulmonary endarterectomy. And how we diagnose it, I showed you some of the tests that we do. But for most of you guys, if you see someone with acute PE, maybe consider follow-up with VQ scan in the future. And if it continues to be abnormal, I think this patient needs to be evaluated by someone who knows pulmonary hypertension. And this is the surgery that I talked about. If done in the right setting, it has a very acceptable mortality, somewhere around 4 to 7%, compared to a mortality of 90% if we don't do it. So that's where the trade-off. There is nothing free. Anything you do comes with risk. And we've been lucky. We've done several cases at Cleveland Clinic so far. And we had a very good success so far. But I hope it continues because even in the best places, mortality is somewhere around 4 to 7%. Some patients are not candidate to medical therapy. And in this case, the patient was lucky that we were able to do it. But sometimes we use medical therapy. There are specific drugs we use for this. But more recently, in the last probably 10 years, there is another procedure called pulmonary balloon angioplasty, similar to what they do in cardiology, but it's a big balloon that goes into pulmonary artery and dilate the vessel. And it has a very good success rate, but it comes with also some complication. So this is an option for people who are not candidate to surgical therapy. So to summarize, I hope by now you guys recognize the difference between the concept of acute and chronic PE. I hope you start recognizing that there is risk stratification. A patient with acute PE, you see on the CT scan, they have absolutely everything is normal. This patient, you can give them anticoagulation, send them home from the emergency room. But there is a patient like this one, or someone in shock, you probably admit them to ICU, put them on a lot of therapy to help them, including thrombolysis or catheter-guided therapy, or ECMO if they have it available. And I want you to understand the treatment options for all these different groups that I mentioned. The other piece, I hope by this presentation, I made you aware of what we think, what does RV failure mean? Recognizing RV failure clinically, someone with JVD, low cardiac output state, edema, congestive hepatopathy, low lactate or high lactate, indicating low cardiac output. Those are markers of right ventricular failure. If you do an echo, the RV looks severely dilated, right atrium is dilated, the patient looks terrible. It's almost always a combination of the constellation of clinical, lab, and echo. If you are lucky and you have access to a cath lab and you do a right heart cath, I showed you the criteria for right ventricular failure. I didn't talk about, there are 2 types of right ventricular failure. Right ventricular failure, preserved cardiac output, and most of you have seen those patients. And I discussed this one, which is right ventricular failure with low cardiac output. The first group is what you see in patients with left heart disease, patient with congestive heart failure. Left ventricle is failing, right ventricle is failing. How I treat them? I don't treat anything like I showed you. I treat them with diuresis. I may use inotrope, but you don't give them pulmonary vascular therapy. You don't do any of that stuff. So that preserved versus reduced cardiac output is fundamental in the approach to these patients. And finally, when you talk about treatment of RV failure with low cardiac output, I hope you start recognizing those 4 critical components. Optimize the preload with diuresis, optimize the afterload with pulmonary vascular therapy, improve cardiac output with inotrope, and maintain systolic blood pressure throughout the case.